Dear colleagues around the globe, this is a video clip of a webinar lecture I was able to present on May 20 for the online congress on regenerative dentistry organized by Geistlich. A big pleasure for me to be part of this excellent one-day course.
So the last presenter is Professor Boozer, and he is going to talk about the excellence of the grafting techniques that they're using in Bern. Please, Danny, go ahead with your presentation.
Hello, good evening, Istvan. I hope you can hear me. It's a really big pleasure to be back. I have been listening almost the entire Congress, and I'm very pleased to see the quality and also the excellent discussions we had. Now I want to share my screen, and I hope that this time the topic of my lecture is the long-term stability of contour augmentation using GBR. And why does it work so well? Now, contour augmentation is one of the augmentation techniques used in daily practice in implant dentistry. Before we start, I want to give you greetings from my hometown Bern in Switzerland, which is a rather small city compared to many others on the globe. You see, we are not too far away from the Swiss Alps. We have an excellent, nice old city. And the School of Dental Medicine, where I've been working since 1980, is today one of the top 10 dental schools in the world, and this for 3 years in a row. We are very proud for this achievement, and it's mainly due to our research output, strong research in the field of implant dentistry and periodontology and others. We're going to talk about 30 years of development and progress of GBR, and I will show you this slide several times with important steps done to improve the technique over the 30 years. When we talk about 30 years, then I also want to mention the upcoming the third edition of the GBR book, talking about 30 years of guided bone regeneration. And you see the stellar list of contributors. That includes the Bernese team, but then also of course, other friends and collaborators such as Stephen Chen, you see Sasha Jovanovic, Isabella Rocchietta, Frank Schwartz, and last but not least, our moderator, Istvan Urban. The release date is now set for January 2021. It was originally planned for October 2020 at the EAO Congress, but now this Congress has been cancelled. As a typical Congress, it will be probably a virtual Congress, and therefore doesn't make sense to release a book when we have a virtual Congress. When we talk about the progress in the field of implant dentistry, we are in a phase of routine. We treat many patients in our department, more than 550 a year. More than 90% today are partially edentulous, with the number one indication for implant therapy, the single tooth replacement. Many patients belong to the baby boomer generation, so the mean age of our patient pool today is 63 years. We can offer excellent long-term results to our patients, and that's very important to give them a lot of confidence for this decision to go for implant therapy. We also made significant progress since the millennium change with aesthetic outcomes of implant therapy. So when I look back all the years, I think the most important key factor for this progress has been successful bone augmentation in daily practice, and that includes GBR, but also, of course, sinus grafting or sinus floor elevation procedures. So when we look at long-term cases, here you see 4 aesthetic cases. On the left side, a 10-year follow-up case. On the right side, a 25-year-old follow-up case. All of them treated with Professor Belzer. You can see that you see the circumferential anchorage of these implants with bone, mainly on the facial aspect, to re-establish an intact facial bone wall is probably one of the most important ones. It also improves the aesthetic outcome. The next case is another 25-year-old documentation with successful ridge augmentation using block grafts and Gore-Tex membranes done in 1994. The follow-up of this in the meantime, an 85-year-old patient shows excellent intact buccal bone walls for both implants, where we had in the beginning only a 3.5 millimeter of crest width. We also see excellent results with sinus floor elevation here, a 20-year follow-up documentation, a very important internal vertical bone augmentation in the posterior maxilla. When you look at the long-term data from our patients at University of Bern, you see we have an abundance of publications in the top journals. It started all in 1990 with a one-year prospective study, and that of course was followed up on different patient pools with multiple papers in recent years on 10 years of follow-up. This slide shows 3 of these 10-year studies. The 2 latter ones are by Vivian Chapuis, one on the GBR staged approach and the other one on GBR simultaneous approach. And you see we have here survival and success rates between 95 and 98%. That gives us a lot of confidence that these procedures really do work. Now, what are the important 4 crucial points from a surgical point of view? You have to select an appropriate implant. Then we talk about the implant length, diameter, and strength. The surface is important. Then we put them in a correct position. This has been addressed today several times. Then, as I said, implants must be completely embedded in bone. In particular, should have a facial buccal bone wall which is intact, and not at day of surgery. That should be intact at completion of bone healing. So 2, 3, 6 months later, depending on the bone grafting procedure you do. And last but not least, the implant should be located in keratinized mucosa. Very important for the long-term stability as well. Today we're going to talk how to rebuild a facial bone wall, because we know from the Araujo papers in post-extraction cases you lose a lot of bone by bundle bone resorption. When we look into different types of implant surgeries, we have implant placement into post-extraction sites, and we have implant placement into healed sites. Healed sites have been the standard of care in the 1980s, in the days of Bronnemark and Schroeder, you see. And there, of course, you can have a wide ridge and you get a thick buccal wall. You can have a thin buccal wall. Of course, there is a lack of bone, then there would be no buccal wall. In post-extraction sites, this was discussed today as well. You can have a thick wall phenotype, more than 1 millimeter, thin wall phenotype, or no facial wall, just a discussion of the 2 previous papers we have been listening this evening. When we look into the different types of augmentation, we have vertical bone augmentation, what Istvan showed so beautifully. That's a one-wall defect. That's the most difficult anatomic situation for augmentation. And when we talk about horizontal bone augmentation, then there we should differentiate between 3-wall defects, 2-wall defects, and 1-wall defect. A 1-wall defect is again a healed site, whereas a 3-wall and a 2-wall defect is a post-extraction situation. Now, my lecture will just concentrate on 2-wall defects. Often the case when we have an early placement protocol, we do then contour augmentation, and this is in about 70% of the patients we treat, and we do when we have to use GBR procedures. Okay, I want to quickly address this two-wall defect concept. You see, the implant is placed in a correct position. The exposed implant surface is inside the alveolar housing or bony housing, as Sasha says, and you have one wall defect here and the other wall defect, also two walls providing the elements for bone regeneration. We can differentiate the defect types. You can have a defect which is narrow and deep. Joseph Kahn calls that V-shape and deep. Then you can have a wide defect or a U-type and medium deep. And you can have very wide W shape and shallow. And then when this gets more and more, then all of a sudden you have a one wall defect. So the exposed implant surface is outside the alveolar or bony housing. So from here to here, the predictability of bone augmentation is reduced because the biological situation is more difficult for Mother Nature. Counterrotation was established in the late 1990s. It was actually an intense discussion we had with Professor Robert Schenk, at that time an emeritus professor. He deserves a lot of the credit what we have learned in the field of GBR healing, in GBR defects. The main issue is that we are using a two-layer composite graft. It's a composite graft like what Istvan is doing for vertical augmentation. When we have a two-wall defect, then we do a layering. So we have two layers, autologous bone chips to accelerate bone formation, and the hydroxyapatite-based filler, DBBM, as a bovine filler, for volume improvement and volume maintenance because it has a low substitution rate. In these counter-augmentation cases, we can always use a collagen membrane because it's horizontal augmentation, and this is only a temporary barrier for about 4-6 weeks. We don't need a longer barrier function, and we don't need an open flap procedure. We always use a primary wound closure. Now, this was developed based on preclinical studies, animal studies with histomorphometry. You see that was done here, a first paper in 1998. Here you see 25 years of research by the Bernese group, and you see the type of defects we have been creating in the posterior area of the mandibular angle of miniature pigs. And then we filled them up with different fillers and put a Gore-Tex membrane on top to exclude the participation of the soft tissues. And I show you here then, of course, the histomorphometry, which was done by Bob Schenk at that time, later on then by Dieter Bossart. And here you see two papers by Simon Jensen, an ITI scholar, who was in Bern for a couple of years and as a researcher from Copenhagen. And you see the osteogenic potential has always been clearly the best for autologous bone chips because they release growth factors, they stimulate the growth of bone, whereas when we talk about volume stability, the substitution rate, then the clear winner is always DBBM. We have now 7 published papers with extremely consistent data. And here you see the osteogenic potential of autogenous bone. This is a 4-week specimen from the 98 paper. You see Bob Schenk got extremely excited about that, to see that such a large defect is bridged over in 4 weeks. When we went into 5 millimeter defects, we could even see that in 2-week specimens, a complete bridging over. So that is the osteogenic potential of autologous bone. Then what we did learn later on, in the year 2005, a major paper has been published by Araujo, ridge alterations and bundle bone resorption. That was actually the basis then for the discussion on the timing of implant placement, post-extraction, very important issue from a clinical point of view. ITI picked it up and then at 4 consensus conferences addressed this issue several times. The first one in 2003, a paper by Hammerle, then 2008, papers by Stephen Chen, and then later on by Dean Morton, and then also by Herman Gallucci. So you have 4 different treatment options, and all of them I use today, but not to the same percentage. I'm not so aggressive like our friends from Brazil. I have a lot of concern about this approach because we learned this morning by Dr. Yildiz, you see that he's fixing a lot of failed implants, aesthetic disasters, and the majority of these implants are immediate implants. So out in the field, there are not too many people who can do that properly, and that causes a lot of damage to patients. So I think it's very important, these selection criteria, when to use immediate implants, when to use early placement, when to use late placement. All modalities can be used, but you need to have defined selection criteria. My topic is on early placement with contour augmentation, so we wait 4, 6, or 8 weeks, depending on the size of the tooth which is extracted. And you see here how we do that. When there is a thin or no buccal wall, then we are not using any immediate implant placement. Then we go for early placement. We need enough bone, as you can see here, to go for a 2-wall defect, but we know from a study by Vivian Chapri that we always have that in a post-extraction case after 8 weeks of healing. So here you see the first case we did in 98. You see here, patient was 6 weeks post-extraction, first premolar, and you see the procedure we have done, autogenous bone, bios, and a collagen membrane, primary closure. And here you see the patient 20 years later. You see here fully intact buccal wall, thick buccal wall, and I'm very pleased with this outcome. Then later on in the early 2000s, many tissue level implants placed with early placement protocol. Here you see and probably narrow defect, medium depth. You see autogenous bone, DBBM, collagen membrane, primary closure. Here you see the patient then 12 years down the road, and you see the implant is very well integrated. It's a tissue level implant, and you see here a fully intact buccal bone wall. Then we made a switch to platform switching implants. These are so-called bone level implants by Straumann. You see here a typical case, extraction 2006, and then healed after 8 weeks. Bundle bone is gone. We have a spontaneous soft tissue thickening, so we don't do any socket grafting in a case like this, just a collagen plug. Then you see the defect we have, and we rebuild that bone with this technique. And you see then the primary closure, reopening at that time was 3 months. And here you see the patient 10 years later as part of a prospective case series study on 20 patients. Extremely stable situation. You see the convexity, the implant shows no sign of bone loss, and you see a fully intact buccal wall, and the peak of the facial wall is about 1 millimeter coronal to the implant shoulder. Okay. We can do the same in 2 missing centrals, much more tricky, complex procedure. And here you see now we did 8 weeks of healing, implant placement, we augmented, we also augmented in between the 2 implants. We go for stabilization of the bios particles with a fibrin sealant, I will show you later. Primary closure following membrane application, then at reopening 3 months at that time. And you see here then at the final restoration done by Professor Belzer. And here you see the same patient 11 years later. And you can see that we have a full intact buccal wall, not extremely thick. Today we get better results, as I will show you later, but it's full intact. You see the peak here on top of the shoulder. And also look this bone volume in between the 2 implants, no bone loss, so really nice. We of course did also that in mandible. In the mandible it's much more tricky because there the bone fillers have a tendency to glide apically. You see here a healed site, so actually a major atrophy, horizontal atrophy. So the implant bed was prepared. Then we had a very knife edge reach here, you see, so I took that down. I always do that in my patients for almost 20 years now. You see, to get a horizontal component in the defect, we open up the marrow cavity, take autogenous bone, fill in then the autogenous bone to this defect, and the horizontal component will stabilize my autogenous bone chips to stabilize more than even we use this fibrin sealant. It's called TIS seal from Baxter. And then, of course, we have a second layer of the DBBM, again, T-seal to stabilize, then membrane, and then primary closure. So this is a patient I have seen just last week. This is now 15 years later. You see very stable soft tissues, implant perfectly integrated 15 years later, and look, the facial bone wall fully intact. And when I show you again what we had, it was about a 6 millimeter defect on the buccal aspect. So we are very pleased with that. With the patients we treated in between 2000 and 2010, we did 2 cohort studies, one prospective up to 10 years. This is the last paper here by Vivian Chapuis. Here you see the paper by Chapuis and colleagues in the Journal of Dental Research, that's a top journal. 0 dropout. So we showed in all these papers all 21 patients from a clinic point of view, PES measurements, and of course the radiographs. I'll show you only the cone beams we have provided at 10 years. And 14 patients, that means 70% at the full intact buccal wall and the peak coronally to the implant shoulder. Then 25%, meaning 5 patients had a full intact buccal wall, but the first bone to implant contact was slightly below the implant shoulder. And we had 1 failed case where there was no bone formation, so a 5% failure rate in this study as outlined in the paper. So when we look at the mean values, the mean value was 1.7 millimeter at 10 years, the thickness, and 0.26 millimeter, the distance from the implant shoulder to the peak coronally to that implant shoulder. So very pleasing data. What else did we do? You see, fine-tuning efforts have been done to improve the procedure, to reduce the morbidity. One, we started to have a cell biology lab, and we looked into the role of autologous bone chips. You see, this is completely underused in the United States, which is a complete pity, because they still believe when you take autogenous bone, you have to open up the chin, which is complete nonsense, you see. So the studies that we have published in the top journals by our group, you see, is mainly driven in the beginning by Reinhard Gruber. He's now back in Vienna, member of the osteology board, then later on by Jordi Gabaye from Barcelona, and Rick Myron, who's now back in the States somewhere, and most recently Maria Asparuova, you see it here. You see, what we analyze is we took the bone and put them into blood and serum combination to see how quick we get growth factors. And here you see the most recent paper in International Journal of Oral Science, high impact journal. You see that we get a very quick release of TGF-beta into this BCM. This is ringer solution and blood serum, you see. And we also get BMP2, but it takes some days to really pick up. So when you apply the autogenous bone into the defect, they start to release the BMP2 after a couple of days. And you see, that's the interplay we have between the two, these very important growth factors, TGF-beta1 as a proliferation factor, to make sure that these precursor cells move into the defect from the bony walls, and the BMP2 a differentiation and mineralization factor. So these osteoblasts form, they duplicate, and they start to produce the osteoid and then mineralize the osteoid. So this is done as you can see it here. You see that when the flap is raised, we immediately take the blood, and then we mix that with ringer solution as a natrium chloride, so it's not coagulating. See, I'm sure this is by far better than any PRP or PRF, I don't know what, because this is coming from the bone, these growth factors. Then we take locally the bone chips with a sharp bone scraper we use from Hufredi, a reusable bone scraper. You just have to resharpen them from time to time. And you see now these chips go into the blood bath. They are about 1.5 to 2 millimeters in size. You can all read that in the papers we have published. So that goes into the blood. And then we continue the implant bed preparation, the defect preparation. And after 15 to 20 minutes, we take a syringe and we aspirate this BCM blood growth factor mixture. And now, of course, we use that to activate the DBBM. So this is an instant biologic activation of this non-active bone filler. Now, all fillers are active because they have all these TGF-beta 1. So when I show you a recent case done in 2016, you see the tooth has been extracted very carefully. You measure the width of the crest, 6+ millimeters, so that's no problem. Then a triangular flap implant bed preparation. The bone has been taken. We always use a 2 millimeter healing cap, and then we do an autogenous bone application first. Small volume, so you don't need a large quantity of bone chips. Then you do the contour, over contour augmentation with the DBBM, and then a 2 double layer technique with the collagen membrane all soaked in BCM. Then a tension-free flap closure. Patient will have some swelling in the first 2 days or so, or 3-4 days, and then it's diminished again. Here you see then how we are using this correct positioning. This concept of comfort zones was published from an ITI consensus paper 2003. So this is a highly cited paper these days, more than 500 citations. And today we are using 8 weeks of healing for more than 10 years now, which is the absolute routine for contour augmentation, 2-wall defects. So you see that lady at reopening at 8 weeks, a punch technique, no roll flaps, nothing like this. In a routine, I never use a connective tissue graft, so there is no need for soft tissue grafting in cases like this. This is very rarely done in these routine cases. We use most of the connective tissue grafts in failed implants, aesthetic disaster cases when there is a lot of recession. You see the patient at 3.5 years. You see the implant well integrated, and look this facial bone wall. That's the type of facial bone wall we get when we are using the BCM technique. So you just get more bone formation, and you see beautiful in a horizontal cut the bone. We also have another case here where I want to show you the surgery again in a couple of video clips. You see we collect the blood, we collect the bone, the chips go into the blood bath. You see, here you see the blood. And then we continue, we do the implant bed preparation. We prepare the defect. When there are sharp edges here, we always take the sharp edges off because they're gonna be resorbed anyhow. Then we put an implant in. This is mainly used here, the bone level implant as a platform switching implant. And then, of course, we make sure that we go deep enough, about 3 millimeters below the future mucosal margin. The palatal wall has to be above the shoulder, or the shoulder should be subcrestally, very important. And then you see here we do the preparation with the BCM. We take the blood and soak it into the DBBM. You see we apply autogenous bone chips first. Then we apply the DBBM particles, and then we start to trim a 25 by 25 millimeter collagen membrane. And the collagen membrane is applied always in a double layer technique. Here you see then how it is done. In these kind of cases, there is no need for tacks. I love to use tacks in the mandible, as I will show in the last case, when there is a risk that the blood, the bone fillers could glide apically, and then the tacks are extremely useful, as you have seen already in this fantastic presentation by Istvan. And then, of course, primary closure, tension-free, if needed, vertical or horizontal mattress sutures, 5-0 sutures, releasing incision with 6-0 sutures. And here you see the final treatment outcome of this patient done by Professor Belzer. This is the implant crown. Look the quality of the tissue. Here you see the perfectly integrated bone level implant. We couldn't get a cone beam in February because we had closed dental school due to the pandemic situation. I show you another case with 2 missing centrals. You see 8 weeks of healing, then the surgery, and you see the same steps all the time. You see here again the fibrin sealant to stabilize the membrane, a large piece of membrane, primary closure, reopening at 8 weeks. Here you see the final outcome 3.5 years later. And look here, excellent bone in between both implants, and look the thickness of these facial walls. Excellent BCM augmentation, activation of the BIOS with TGF-beta 1. Okay, last point is narrow diameter implants that came to the market about 10 years ago. It helped us, this rock solid alloy, helped us to use them more often in the posterior, so we could actually get better defect morphology. Here you see a case like this. This is a very narrow reach, probably about 4 millimeters. And here huge undercut, so we can place 2 implants here. So we open up, we prepare the implant bed where we take the bone. You see then this is extremely thin facial wall. So we take the bone off, horizontal component. We use 2 tacks in this case with a collagen membrane. Implants are placed, as you can see here, and you see the borderline situation that's almost at the surface of the bone, but we are using a lot of autogenous bone, and then the DBBM, and then we stabilize it. And then, of course, we have an extremely stable membrane because of the 2 tacks used on the apical area, and then a tension-free closure, reopening at 8 weeks. You see here the tacks were left in place, and here you see the 1-year follow-up, and you see this is the kind of results we have seen from IST1. The stability of the membrane with the tacks really helps you to get excellent augmentation outcomes here, as I have seen in about 10 patients I did in the last 2 years. Let me come to the conclusion. Okay, the conclusion is, first, the evidence. Simultaneous contour is one of the augmentation procedures we use. It's well documented, up to 10 years prospective studies. It requires a 2-wall defect, and contour augmentation is done with a 2-layer composite graft and a barrier membrane. See, when we talk about the key factors, you see the 2-wall defect I mentioned, the 2-layer composite graft with an autologous bone that they are locally harvested, so no additional morbidity, but they speed up bone formation and they speed up healing, so it's quicker. Second, the DBBM gives you more volume to augment, and it gives you more volume stability over time because it has a low substitution rate. The collagen membrane is easy to apply, has a temporary barrier function, low complication rate, and you don't have a second open flap procedure, in particular in the aesthetic zone, and a primary wound closure. The last one is the progress. You see, we have seen better results in the last 5-6 years since we understood the BCM technique, that is growth factor release. Autologous bone chips really are a tremendous value in combination with DBBM. We made significant progress to reduce the morbidity for patients as well. And that helped us, of course, to have these narrow diameter implants, which optimize often the defect morphology. We can do more often simultaneous or even without GBR. And therefore, the block grafting with a staged approach could be reduced now in our department to less than 5%. And in the early 2000s, we were almost at 20% in daily practice. With that one, I would like to acknowledge all the people helping for many, many years in this research. Of course, our beloved Bob Schenk, who gave us such a tremendous input, and his knowledge was fabulous, and he was just a nice guy. Then Dieter Bossart, who was an excellent successor. Then, of course, Professor Urs Belzer as a partner in the prosthetic field, and of course also Professor Vivian Chapri, the last 10 years, who took over now the chair position. She's an excellent surgeon, and we are very positive that she will be a really good successor in this position. If you're interested in our master courses, we have always sold out situations. We still hope to have then our GBR course originally in June, now then taking place in November. And the aesthetic master course with Professor Belzer has been moved already to March 21. with that one, I would like to thank you so much for your online attention. If you want to have a handout, you can send it. I will also have a video clip of my presentation. I will put it to our YouTube channel so you have a chance to listen and look at this again. Okay, thank you very much.
Thank you very much, Danny. It was a wonderful presentation, amazing documentation. Honestly, when I'm working on a manuscript, I like to pull the GDR paper, the 10-year follow-up paper that you published, both the contour augmentation and the blog, because I think it's so nicely documented and followed up. So when I'm working on something, I'm looking at, okay, I should get close to that, but it's going to be very difficult. So
yeah, and you have a little bit more difficult situation. I had a huge department that helped me, of course, but teamwork is that's the number one prerequisite for success in research. You need to have a strong team, otherwise you can't do it.
Yeah, so it's very, very convincing. You know, you have the I believe like a 1.69 millimeters of bone thickness after 10 years after this contour augmentation, the very good coronal level of bone. And you mentioned that you don't do, rarely do any connective tissue graft. And you shown some amazing, beautiful cases together with Professor Belzer. I'm referring to the 2 center incisor with the papilla. Yeah. I mean, for like that would be on a highlight for like an aesthetic lecture. Or the other one with the center incisor was also perfect. Yeah. The papillary level, I was checking, you know, to see any mistakes, but I couldn't find any. So, but basically, the main reason I believe that you don't really need for those cases the connective tissue graft, however, we do a lot of connective tissue grafts, is that you also publish that once you extract, you basically the tissue is gaining. So it's like a nature provides you a little bit of
yes.
tissue thickening before
yes.
you do the augmentation.
I mentioned that only briefly, but when you pull a tooth, you need to know what you're going to do. So I love to use socket grafting when I know I'm going to place an implant in 4 months, and then I do it often today, flapless, computer assisted, mainly in elderly patients or in patients with medical risk factors. And of course, not a center incisor, I guess. But premolars, I love to do that because it's really minimizing then the invasiveness for the patient. But then I know high aesthetic demand, and I go back in at 4 weeks, 6 weeks, or 8 weeks, depending on the tooth. When it's a center incisor, it's often 6 or 8 weeks. Then I don't do anything with that socket. So I let the soft tissue grow in, because in a single tooth situation, the volume of the bone next to that extraction socket will not change at all. It was shown by this paper of Vivian Chapuis. That means the soft tissue grows in, you see like an excellent ridge, and then you do a palatal incision, and you just take the whole soft tissue as part of your flap. So this is like a built-in connective tissue graft, but it's vascularized. So that gives us the chance that in most of these cases, there's no need for connective tissue grafting.
Yeah, that's what I meant. But for those beautiful crowns, you need a very good prosthodontist and a very good lab. Which in Switzerland is.
I think I should probably also add the technician to my acknowledgement slide, because this is Pascal Müller from Zurich. He just did from me some veneers in my teeth. You see, he's a fabulous guy. And Belzer, when it really goes for the best, then he sends all the patients to Zurich, to Pascal Müller. And of course, he's not cheap, but he spends much more time on these cases, and the patients are very satisfied with his excellent performance. Mm-hmm. Again, teamwork.
Yeah, we know Nicola Pietrabon in Zurich, who is also a very, very good. So it's also, I also love the research about the TGF-beta1 and the BMP2, how the TGF-beta1 is basically collecting, and then the BMP2 is basically doing the differentiation. The BCM technique is basically you're collecting blood, I believe, then you put it to the chips, chips release, and then you transfer that to the BIOS to activate the BIOS at the time of graft.
And use the beauties, and that's the problem. And the two of us have always been using in the last, I don't know how many years, autogenous bone. Huh? But the problem is in countries where, let's say, where marketing is very strong, most of clinicians are not using autogenous bone because no company can sell autogenous bone. So there is no money to make with this, you see. But actually, I had a long time to convince Geistlich, you see, that autogenous bone is not a competitor to BIOS. It's actually, it's a positive factor because it makes BIOS much better. So actually today that this discussion is finished, but 20 years ago, they were always arguing against, you see. So I think this is very interesting. We are just in the final phase of a new publication that shows beautifully how BIOS picks up, also how this is attached to BIOS and how this interferes. And then in addition, we do now the same study again, but this time with human bone chips, because the previous study was done with bone chips from pig mandibles, from the butchery. And we want to repeat that. And I think we have done about 10 patients yet. And Maria Sporio tells us exactly the same data, not a surprise to us. So I think there is still a lot of research to be done, and we would love to see other groups to pick it up and also go into these details. It's a very interesting biological question.
Mm-hmm. Very good. So I just have two more remarks.
Yes.
That I picked up. One is the T-seal. I think that was very good to stabilize the Baxter product that you mentioned, and also the one when you applied the pins on the lingual or on the apical, then you showed the CT scan, and you could see that actually the graft wanted to migrate.
Yeah,
and it was like the membrane held it, and the pins were holding it in place really nicely. I don't know if anybody picked it up, but that is a perfect CT scan to show what the this whole thing stabilization can do with a particulated bone graft.
Actually, one of the screws is overgrown by the bone from the top. So to take it out would be not so easy, I guess. So I told the patient, look, we'll leave it in place because it only disturbs our eyes when you look at the radiographs. So if it's not doing anything, it's like an implant. You see, it's a titanium screw. So I love this technique when we have very demanding anatomy. Also, posterior mandible, of course, is a problem. I don't have to tell you that. So there, the gravity is your enemy, as I say. You see, the bone fillers try to glide apically, and you need to stop to do that. In the maxilla, when they glide apically, actually then they glide coronally because then they go down and it's in our favor. So actually in the mandible, gravity is a problem.
Much worse. Yeah.
Yeah.
All righty. Thank you so much for this presentation, for this day, and for your moderation also in the morning. I think with the afternoon session, I think I loved it also. This 5 hours just passed very, very fast. I really enjoyed the whole Congress because I think really this was a Congress. I really loved the idea to have the you that you could apply and be a speaker. And I think all 4 speakers were excellent. We love that. And thank you so much for all the speakers for the presentation and the effort. Also the company Geistlich to put so much energy into this, to Mirko especially, who did in a Swiss precision way organized everything perfectly. And so I think I also thank all the audience who were here. Some of you maybe were here the whole day, I don't know, but thank you so much for the large numbers you were here. I really wish you the best, and I hope you stay safe. I think we still have this virus around for a while, but I think we learn how to live with around this, and we're gonna go back to our normal life. Thank you so much.
Yes, this concludes now this video clip. As I mentioned before, if you have an interest to see how these surgical techniques are applied in patients with live surgeries, then I can only encourage you to come to Bern and to see these procedures offered and presented by our team. we have welcomed in the past 20 years hundreds of colleagues from all over the place. We continue to do that. We have next GBR master course scheduled in November, and we hope that the pandemic will allow that. And then the next master's course in aesthetic implant dentistry, a combined course with Professor Belzer and Professor Chapuis, myself, will then be organized and offered in March next year. So all the best, stay safe, and bye-bye.